าบันมะเร็งแห่งชาติกรมการแพทย์หนึ่งในสถาบันชั้นนำด้านการรักษาโรคมะเร็งโดยวิธีการผ่าตัดการผ่าตัดยังคงเป็นวิธีการรักษาหลักที่หวังผลในขาดได้ในการรักษามะเร็งหลายๆระบบมะเร็งของระบบตับอ่อนและทางเดินน้ำดีเป็นปัญหาที่สำคัญและพบได้บ่อยการผ่าตัดโดยวิธีการส่องกล้องในผู้ป่วยมะเร็งระบบนี้ให้ผลการรักษาที่เทียบเท่าหรือดีกว่าการผ่าตัดโดยวิธีการเปิดผนังหน้าท้องเช่นการเสียเลือดขณะผ่าตัดน้อยกว่าผู้ป่วยฟื้นตัวได้เร็วกว่าเจ็บแผลน้อยกว่าการวินิจฉัยและประเมินผู้ป่วยก่อนผ่าตัดเป็นหนึ่งในปัจจัยที่สำคัญมากที่ทำให้ผลการรักษาเป็นที่น่าพอใจ
การประเมินผู้ป่วยก่อนได้รับการผ่าตัดที่สถาบันมะเร็งของเราที่เราใช้นั้นเนี่ยมีอยู่2ส่วนครับส่วนแรกคือการตรวจวัด ICG ส่วนที่2คือการตรวจวัดปริมาตรของตับการวัด ICG นั้นเป็นการประเมินว่าผู้ป่วยรายนั้นเนี่ยสามารถตัดตัวตับได้จำนวนมากน้อยแค่ไหนส่วนการวัดปริมาตรของตับนั้นเป็นการวัดปริมาตรของตับส่วนที่เหลืออยู่ที่คาดว่าจะเหลือจากการผ่าตัดว่าเป็นปริมาณแค่ไหนการนำ2อย่างนั้นมารวมกันจะทำให้การผ่าตัดนั้นได้รับความปลอดภัยมากยิ่งขึ้นในสถาบันของเรานั้นเนี่ยการผ่าตัดที่ได้ประเมินทั้ง2อย่างร่วมกันนั้นพบว่ามีผลแทรกซ้อนจากการผ่าตัดเกิดขึ้นน้อยมากครับ
สำหรับเทคโนโลยีการผ่าตัดมะเร็งตับอ่อนด้วยวิธีการส่องกล้องนะครับในปัจจุบันนี้ก็ถือว่าได้รับความนิยมอย่างสูงแล้วก็เป็นมาตรฐานมากขึ้นนะครับส่วนเทคโนโลยีที่เราใช้ในสถาบันมะเร็งแห่งชาติเนี่ยอันดับหนึ่งเลยคือกล้องผ่าตัดของเราเนี่ยก็มีความคมชัดในระดับ 4K นะครับก็มีความละเอียดสูงมากทำให้การผ่าตัดเนี่ยสามารถเห็นเส้นเลือดที่อยู่บริเวณตับอ่อนได้ชัดเจนนะครับรวมถึงเรายังมีกล้องโฟลูออเรสเซนต์นะครับสามารถดีเทคสารอินโดไซยานีนกรีนนะครับซึ่งเมื่อเราใช้ร่วมกับการใช้อัลตราซาวด์ในระหว่างผ่าตัดเนี่ยทำให้เราสามารถผ่าตัดตับอ่อนได้อย่างปลอดภัยแล้วก็ได้ขอบเขตการผ่าตัดได้ดีครับรวมถึงสามารถดูได้ว่าม้ามสามารถเก็บได้หรือไม่นะครับซึ่งถ้าคนไข้สามารถเก็บม้ามหลังจากการผ่าตัดตับอ่อนไปได้เนี่ยก็ทำให้ความเสี่ยงในการติดเชื้อรุนแรงหลังจากการผ่าตัดเนี่ยลดน้อยลงทำให้การผ่าตัดตับอ่อนเนี่ยมีความปลอดภัย
สำหรับ IORT หรือ Intraoperative Radiation Therapy เนี่ยเป็นเครื่องมือที่ใช้ในการฉายรังสีทันทีหลังจากที่มีการผ่าตัดเอาเนื้องอกออกจากตัวผู้ป่วยแล้วเป็นการฉายรังสีครั้งเดียวในปริมาณที่มากเพียงพอโดยมีผลกระทบต่ออวัยวะข้างเคียงค่อนข้างต่ำโดยเราจะเลือกใช้ในกลุ่มผู้ป่วยมะเร็งที่มีการลุกลามไปที่ต่อมน้ำเหลืองหรือหลอดเลือดบริเวณใกล้เคียงค่ะอีกหนึ่งเทคโนโลยีที่ใช้ในผู้ป่วยที่ไม่สามารถเข้ารับการผ่าตัดได้ซึ่งก็คือ IRE เป็นเครื่องมือทางการแพทย์ที่ใช้ในการทำลายเซลล์มะเร็งโดยอาศัยคลื่นไฟฟ้าไปทำลายเซลล์มะเร็งทำให้เกิดรูขนาดเล็กอย่างถาวรจึงทำให้ตัวเซลล์มะเร็งนี้เสียสภาพไปในที่สุดซึ่งวิธีการรักษา IRE นี้จะไม่ทำให้เกิดความเสียหายต่อเนื้อเยื่อบริเวณใกล้เคียงมีบาดแผลขนาดเล็กการฟื้นตัวของผู้ป่วยเกิดขึ้นในระยะเวลาอันสั้นค่ะ
นอกเหนือจากการรักษาผู้ป่วยแล้วการพัฒนาและถ่ายทอดองค์ความรู้ด้านการผ่าตัดรักษาโรคมะเร็งก็เป็นอีกหนึ่งภารกิจที่สำคัญของหน่วยมีหลักสูตรการฝึกอบรมศัลยแพทย์ผู้สนใจด้านการผ่าตัดตับโดยวิธีการส่องกล้องทั้งภาคทฤษฎีและปฏิบัติในสถาบันมะเร็งแห่งชาตินอกจากนี้ก็มีการออกหน่วยสอนและแนะนำการผ่าตัดในโรงพยาบาลศูนย์และโรงพยาบาลจังหวัดที่ต้องการพัฒนาการผ่าตัดตับโดยวิธีการส่องกล้องทั่วประเทศหากศัลยแพทย์ท่านใดต้องการพัฒนาทักษะด้านการผ่าตัดโดยวิธีการส่องกล้องสามารถติดต่อมาได้ที่สถาบันมะเร็งแห่งชาติครับ
สวัสดีค่ะ Good evening everyone. Welcome you all to the third NCI Liver Center Webinar, which is today about the lap hepatectomy focusing on the right side. It's a collaboration between National Cancer Institute and Medtronic. Today is very honored to have 5 seasoned experts to share the experience with us and 2 privileged moderators. Before we start, please be informed that if you log in as a participants, you will see only your names and panelists, and your line will be muted to avoid the distortion. But you still can ask your questions by typing to Q&A chat box and another chat box for general communication such as greetings or suggestions. This webinar will be recorded. For privacy and disclaimer, we have requested all the participants, please do not take photo, screenshot or record this webinar. Thank you. Let's meet and welcome our 2 privileged moderators, Dr. Chan and Dr. Chatchai. Thank you.
Thank you very much, Kun. Good evening, everyone from Thailand, and welcome you all to join our third NCI Liver Center Webinar. My name is Dr. Thanin Kakun from Bangkok Hospital, and my co-moderator, Dr. Chatchai Ningmalailak from Thammasat University. How are you, Dr. Chatchai?
Hi, I'm good. Thank you, Dr. Tan. It's a great time to me to be here with you again.
Yes.
Since the last time, the second webinar, let's have a very successful
Yes.
webinar, and I think every participant really enjoy. And I hope today everyone will enjoy this webinar again.
Yes.
How about you?
Yeah, I'm doing well. So we both are excited because this is one of the successful webinar meetings. Currently, we have almost 300 participants registered already. So our topic today is about the laparoscopic hepatectomy, focusing on the right side, and it's our privilege to have 5 honorary speakers from Asian Pacific region. Dr. Katsuteru Monden from Japan, Dr. Kyoshin Chen from Taiwan, Dr. Lawisak Janwat from Thailand, Dr. Ji Hun Kim from Korea, and our special lecturer of the expert talk section, Dr. Go Wakabayashi from Japan. So the format of our webinar today, we'll start with the presentations of all 5 speakers, and if you have any questions, please leave in the chat box, and after all presentations, we will have the question and answer along with the panel discussion session. Let's start the meeting, Dr. Chatchai.
Okay, thank you. The first speaker we will start today is Dr. Katsutoru Monden. He graduated from the JKI University School of Medicine, Tokyo, Japan. He has a lot of experience in the HPV surgery. And right now, he practices at the Department of Surgery, Fukuyama City Hospital, Hiroshima, Japan. The topic he will give up today is the anatomy, the landmark, and the variation of the liver, a focus on the right hepatic vein. Let me enjoy for the video from the Dr. Katsutoru Monden, please.
Thank you for providing me with the opportunity to present at this virtual meeting. I am Kazutaro Monden from Fukuyama City Hospital in Japan. Today, I will discuss about anatomy, landmarks, and variations with a focus on the right hepatic vein. The outline of my presentation is as follows. Now, I will proceed with the first topic. The major or larger hepatic veins run between segments or sections. They are used as landmarks to accurately perform dissection of the liver parenchyma during continuous exposure in the cutting plane. In a laparoscopic approach, since surgeons can be easily disoriented, roles of the hepatic veins as landmarks become more meaningful. Herein, I present a case in which the right hepatic vein was used as a landmark during segmentectomy of segment 7. After fully mobilizing the right lobe, the glycinian pedicle of segment 7 was identified and marked using intraoperative ultrasonography from the dorsal side of the liver. We usually apply the intrahepatic glycinian approach because G7 often runs close to the hepatic surface. After a wide dissection between the caudate lobe and segment 7, we proceeded to dissect between segments 6 and 7, and G7 was subsequently identified. After clamping the glycinian pedicle, segment 7 was observed for the ischemic area. After dividing G7, the right hepatic vein was exposed completely from the root to the periphery. The tip of the CUSA was moved toward the periphery to prevent split injury to the tributaries of the hepatic vein. The right hepatic vein runs the boundary of the segments or sectors, thus acting as an anatomical landmark. Following exposure, the right hepatic vein was connected to the demarcation line on the liver surface. These are both landmarks for transecting the appropriate plane. Subsequently, the border between segments 7 and 8 was divided, As the cutting plane is a segmental plane, transection can proceed smoothly. The total operative time was 276 minutes, and the estimated blood loss was 20 milliliters. The patient's post-operative course was uneventful, and he was discharged on post-operative day 6. Next, I will discuss the relationship between the right hepatic vein, inferior right hepatic vein, and middle hepatic vein. Sato reported the anatomy of the right intersectional plane in 200 patients. In 54.5% of cases, the right hepatic vein was completely exposed. Meanwhile, 45.5% of patients exhibited partial exposure of the right hepatic vein. Only approximately half of the patients achieved complete exposure of the right hepatic vein on the right sectional plane. They focused on the inferior right and middle hepatic vein. Partial exposure type is associated with a large inferior right hepatic vein. In addition, the middle hepatic vein was well developed, and it drained some parts of segment 6. Therefore, the peripheral tributary of the middle hepatic vein runs across the transected plane. Moreover, in cases of partial exposure type, the right hepatic vein runs more cranially. In case of transection in the right sectional plane, the right hepatic vein can be used as a landmark when transecting between segments 7 and 8, but not between segments 5 and 6. I will proceed with the case presentation. This case involved a large inferior right hepatic vein. The middle hepatic vein was well developed, and it drained segment 6. Therefore, the right hepatic vein runs more on the cranial side. The middle hepatic vein is an internal landmark during transection between segments 5 and 6. Then, resection is performed, and the right hepatic vein is used as a landmark during transection between segments 7 and 8. In this case, the right hepatic vein was exposed from the vena cava, and it runs cranially. Moreover, during transection of the right sectional plane, not only the right hepatic vein but also the middle hepatic vein serves as a landmark. Next, I will discuss about variations of V8. The drainage vein of segment 8, known as V8, often runs between the ventral and dorsal branches of the G8. V8 is known as the anterior fissure vein. According to a recently published report by NCI, the anterior fissure vein flowed into the middle hepatic vein in 68.9% of patients. In 9.9% of cases, it flowed into the right hepatic vein. Thus, 78.8% of patients had a visible anterior fissure vein. V8 can be utilized as a guiding vein in the anatomic resection of the ventral and dorsal parts of segment 8. First, I will talk about laparoscopic anatomic liver resection of the ventral part of segment 8. The procedure is as follows. The middle hepatic vein is exposed from the root side. Then, the ventral branch of the G8 pedicle is clamped during liver dissection. Once demarcation is confirmed, parenchymal dissection is performed from the cranial side while exposing V8. A 59-year-old woman with a history of hepatitis B virus infection and alcoholic hepatitis, magnetic resonance imaging revealed a 1.3 centimeter liver mass with typical hepatocellular carcinoma features at the ventral part of segment 8. In this case, 2 visible V8 flowed into the distal side of the root of the right hepatic vein. After the identification and marking of the middle hepatic vein, liver parenchymal transection was initiated at the ventral aspect of the root of the middle hepatic vein and was continuously exposed using the CUSA from the root to the periphery. The ventral branch of G8 was identified and clamped. The demarcation line was emphasized via indocyanine green fluorescence imaging and was marked with a cutting line. Dissection was performed from the cranial side while exposing V8. Herein, we identify the middle hepatic vein. 2 V8 flowed into the distal side of the right hepatic vein, and the stump of the ventral branch of G8 was exposed. 1 year after surgery, the patient presented with recurrence of hepatocellular carcinoma in segment 6, and partial liver resection was performed. Then, 1 year and 7 months after the second surgery, HCC was detected close to the right anterior glycinian pedicle in segment 5. The patient underwent laparoscopic anterior sectionectomy for the 3rd time. The adhesions between segment 8 and the diaphragm was divided, and the hepatic hilum was not touched during the first surgery. Hence, isolation of the anterior glycinian pedicle was not difficult. The demarcation was marked. After wide dissection of the liver parenchyma, the anterior glycinian pedicle was divided, and liver resection was completed. Next, I will discuss about laparoscopic anatomic liver resection of the dorsal part of segment 8. We plan to expose the vein-draining segment 8, known as V8, for use in the hepatic vein-guided approach. V8 can be a landmark for approaching the dorsal branch of G8. Following the identification and marking of V8 by intraoperative ultrasound, the confluence of V8 and the middle hepatic vein is confirmed, and V8 is continuously exposed by the CUSA from the root to the periphery. After exposing V8 to some extent, it is grasped and deep transection is performed on it. The dorsal branch of G8 is identified and clamped. The demarcation line is made apparent by indocyanine green fluorescence imaging and is marked as a cutting line. After dissecting the dorsal branch of G8, the root of the right hepatic vein is exposed from the inferior vena cava. Lanix capsule can also be preserved. As you can see, Lanix capsule covers the inferior vena cava and surface of the hepatic vein. This approach is the outer Lanic approach. The right hepatic vein acts as an intrahepatic landmark, while the other landmark is the demarcation line. Both of them were connected to avoid disorientation of the dissection line. Here, we show the right hepatic vein, V8 and the stump of the dorsal branch of G8 were exposed from the inferior vena cava. The total operative time was 319 minutes, and the estimated blood loss was minimal. The patient's post-operative course was uneventful, and she was discharged on post-operative day 6. Lastly, I will discuss about the anatomic structures for identifying the root of the right hepatic vein. According to a previous systematic review, the right inferior phrenic vein drains into the infradiaphragmatic IVC, and the right hepatic vein in 89% and 8% of patients, respectively. In approximately 97% of cases, inferior phrenic vein drainage can be identified via the intra-abdominal cavity. Hence, The inferior phrenic veins are important landmarks when approaching the suprahepatic IVC and the root of the right hepatic vein. Meanwhile, the left inferior phrenic vein drains into the left hepatic vein, IVC, and left adrenal or renal vein in 14%, 46%, and 40% of patients, respectively. The left inferior diaphragmatic vein was visible in 60% of cases. In summary, I have discussed about the use of the right hepatic vein as a landmark and its variations. If you have any comments or questions, please feel free to send an email. Thank you for your attention.
Thank you for Dr. Kasutulu Monden for a wonderful talk today. And anyone who have a question, you can type on the chat box and the speaker will answer in the panelist session. So we will move to the next topic by Dr. Tan, please.
Thank you, Dr. Chatchai. So our next speaker, Dr. Kyo-Chin Chen. So Dr. Chen, he finished his clinical fellow in minimal invasive surgery center at Cleveland Clinic. And he also has his scholarship at Department of HPB and Transplantation Surgery at Kyoto University, Japan. He's also the approved liver and kidney transplant surgeon in Taiwan. His current position is the chairman of the Department of Surgery, Far Eastern Memorial Hospital, New Taipei City, Taiwan. And his topic today is about a laparoscopic right hepatectomy standardized technique. Please, Dr. Chen.
Hello, I'm Dr. Guo-Xin Chen from Far Eastern Memorial Hospital, New Taipei City, Taiwan. First of all, I would like to thank Professor Lois Sakachwang for the opportunity to the third NCI Liver Center Webinar. My topic is laparoscopic right hepatectomy, standardized technique. After the relentless effort of our pioneer surgeons to spread the technique of laparoscopic liver resection, it has been used in more and more patients with various indications. The most important driving forces behind this are the ILLS and the two international consensus meetings. Once considered as advanced procedure, laparoscopic right hepatectomy has become more and more reproducible. Actually, in the survey before the Morioka consensus meeting, laparoscopic right hepatectomy was the third most common procedure in the field of LLR. Laparoscopic right hepatectomy includes several steps. The first one is inflow control, which can be done by extrahepatic Gleasonia approach. This is my preferred way. You can also do individual dissection of right portal vein and the right hepatic artery, which might be indicated in tumor very close to the Gleasonia pedicle or in donor hepatectomy. Because anatomical variation only occurred within the Gleasonia sheath, extrahepatic Gleasonia pedicle dissection is a relatively simple way to avoid accidental injury to the liver remnant site structure. In doing individual dissection, careful interpretation of pre-op image is suggested to avoid injury. The rest of the steps include liver parenchyma dissection, precarpal dissection, and the division of right hepatic vein. Finally, mobilize of the specimen. Anterior approach is the preferred way, especially in patients with large hepatic tumor. Extrahepatic Gleasonia approach is my preferred way to do laparoscopic right hepatectomy. Because it divides the right anterior and posterior pedicle separately will prevent accidental injury to the left side structures. This injury can have happened because of overtraction or anatomic distortion by huge tumor or preoperative portal vein embolization. However, the difficulty differs significantly. It depends on the tissue condition and the severity of liver cirrhosis. So here we are looping the right anterior Gleasonia pedicle with the mini retractor. Then the right posterior Gleasonia pedicle. Here. Then we divide the pedicle between hemodocs one by one. The right anterior Gleasonia pedicle first. Then the right posterior Gleasonia pedicle. In selective highlight dissection, right hepatic artery is usually approached beneath the right hepatic duct. Usually it can be cut once isolated. In this case, we use hemlock to clamp the right hepatic artery. To dissect the right portal vein, we need to open the right border of hepatoduodenal ligament. To confirm the bifurcation and also the depth portal vein is very important. So here we use mini retractor to loop the right portal vein and also confirm the depth portal vein. We will apply a silk stream to control the direction of the right portal vein. Then apply the hemlock to block the inflow to the specimen. This is my preferred way because the limited space make staple very difficult. Then we can observe the surface demarcation. In this patient with huge HCC with right portal vein tumor thrombus BP4, we can get demarcation on the surface after clamping the right hepatic artery. Parenchyma dissection started with harmonic scalpel along the demarcation to find the branches of middle hepatic vein. You can follow the middle hepatic vein until the root to complete the anatomic right hepatectomy. Here we are dividing the V5. More branches will be divided to expose the right border of middle hepatic vein. Then we can approach the root of middle hepatic vein here. The IBC and the root of right hepatic vein was also approached. For the bile duct, we use ICG fluorescence guidance to confirm the bifurcation, then divide it between hemolobes. Pre-cover dissection could be done from the root of right hepatic vein caudally to expose the IBC, or you can do it from below after dividing the hydra structures. The right hepatic vein was divided with vesicular staple. Then the specimen was freed from the surrounding attachment. We almost always use anterior approach in right hepatectomy, especially in patients with huge HCC. Here is one example of pre-cover dissection after identifying the root of right hepatic vein. By following the right border of IBC, you can get access to the retroperitoneal space. Then tunneling the right hepatic vein with mini retractor or other instrument you can use. In this technique, you don't need to dissect the interlobar ligament. Here we do more dissection around the IBC. Finally, we divide the right hepatic vein with a staple. In patients with a huge HCC, the tumor could be very close to the bifurcation of the right anterior and the posterior peritoneal pedicle. Selective highlight dissection is my preferred approach. For the bile duct, hg fluorescent image is useful to determine the cutting point. In this patient, after confirming the bifurcation of the bile duct, we divide the right hepatic duct with a staple. And if you want, you can enhance the bile duct with metallic clip. Right hepatectomy is only indicated in few patients in our practice because of the principle of parenchyma sparing. Here is an example. Huge HECC in right liver with BP3 Polovan tumor thrombus. This is also the case we don't do extrahepatic Graysonia pedicle dissection. Instead, selective highlight dissection will be done. In this patient with huge HECC and BP3 tumor thrombus, I used the selective dissection for right Polovan and the right hepatic artery. Then I did some dissection around the highlight plate until the bifurcation of Graysonia pedicles. After applying bulldog clamp, I cut the bile duct and the highlight plate at the level of right anterior and posterior Graysonia pedicle. Then stump was closed with suture. We closed the bile duct with continuous suture with Pauline. Here is the final appearance of hepatic highlight. This technique can be both reproducible and time-saving. Don't forget to fix the liver remnant. I used to pull the force-bone ligament out of the subxiphoid wound, then suture it to the linear artery. My take-home message is, with the accumulation of surgical experience, not only in individual surgeon but also in the whole society of HBV surgery, laparoscopic major hepatectomy has become more and more reproducible. Standardized surgical steps may help to shorten the learning curve. New technology also helped in some difficult situations. However, appropriate mental shift and a good team backup are still needed to ensure patient safety. Thank you for your attention. I'm more than happy to answer your question.
Thank you very much, Dr. Chen, for the very precise and presentation and also the very nice video. So let's move on to our third speaker.
Okay, the third speaker is a very famous surgeon in Thailand, especially from the laparoscopic hepatectomy, the Dr. Lavisak Chanwat. He graduated from the Chulalongkorn University, Thailand, and he training at the clinical fellowship of the hepatobiliary pancreatic surgery at the Institute of the Gastroenterology, Tokyo Women Medical University, Japan. Right now, he is chairman of the Department of Surgery, the National Cancer Institute of Thailand, the NCI, and is a host for the webinar today. Dr. Virisat will give us a talk for the topic is a procedure based on the right anterior portal pedicles. Please enjoy the video from Dr. Lavisat, please.
Thank you, Chairman, dear all speakers and participants. Today, I will talk about procedures based on right anterior portal pedicles. I have no conflict of interest. I will present full video of two cases. The first case is a patient with a tumor mainly located in segment 5 and segment 8 and underwent left right anterior sectionectomy. Case number 2, the large hepatic adenoma located in segment 8 and will be performed left segment 8 resection. Let's start with case number 1. This is the case of 60 years old Thai female patient with underlying of chronic hepatitis B cirrhosis. She still have good liver function. The patient presented with abdominal pain. MRI revealed 2 SCC in anterior section of right lobe of the liver. This is the first one, and this is the second tumor. Now you can see the landmark vein, middle hepatic vein, and right hepatic vein. This is the right anterior portal pedicle. And in coronal view, you can see the tumor is far away from middle hepatic vein. We plan to perform laparoscopic right anterior sectionectomy with partial resection of 7/4A. The patient was placed on low lithotomy, and the port placement was as illustrated. The operation was started with the parahepatic IVC dissection until we found the root of hepatic vein. Then the hepatoduodenal ligament was encircled, and it was prepared for inflow control. This is the extracorporeal Pringle maneuver technique. Then cystic plate cholecystectomy was done. And info was blocked. This is the hilar region. The peritoneum was cut and the hilar plate was taken down. This is the natural gap between hilar plate and linear capsule. Some part of peritoneum was cut. And now we are enter into the natural gap. It's a avascular gap. Some small Christian pedicle can be transected with a sealing device. Then the right anterior portal pedicle was encircled. And cramp. This is the benefit of extrahepatic Christian approach to create the surface landmark of right anterior section. The ultrasound was used to confirm the location of the tumor and the associating hepatic vein. And the superficial perimeter transection was done by using harmonic shear. And before we start deeper perimeter transection, the inflow was blocked and the CUSA was used. The dissection was performed from the caudal to cephalic direction until we found the landmark vein, the peripheral part of middle hepatic vein. And we use this vein as a guide to its trunk. The V5 was cut and the transection was shifted to the left for safe tumor margin. Then the dissection was created between the surface landmark and the intrahepatic landmark. After we finish the first transection plane, then we try to create the second plane. The important landmark is the root of right hepatic vein. Now we can find the landmark. And the other landmark is right anterior portal pedicle. After we perform hepatotomy to create the adequate space, then the staple was applied easily. After that, we inject the ICG. Within 1 minute, the whole liver was stained except the right anterior section that we will resect. This we call negative stain. And the dissection is go along the fluorescent emitting and non-emitting area, and also along right hepatic vein. Now you can see the right hepatic vein, and this is another surface landmark. The right hepatic vein was fully exposed. At this point, I think the ICG fluorescent imaging is useful for correct dissection plane. And the dissection was continue to the liver capsule. Then the liver capsule was cut. Anyway, the specimen was still in place because of the adhesion. You can see the landmark vein, emitting transection plane, and right anterior portal pedicle stump. Operative time was 320 minutes. Estimated blood loss was 100 milliliter. The patient can discharge on post-operative day 5 without any complication. The pathology confirmed moderately deep SCC with free or margin. Next, the case number 2, 35 years old Thai female patient with history of oral contraceptive use, presented with abdominal pain. CT scan revealed large hypervascular mass in segment 8. V8 was visualized. V4 and V5 were joined together to form the middle hepatic vein. G8 was close to V5 trunk. This patient has superior, middle, and inferior right hepatic vein variation. Because of the complexity of real intrahepatic structures, the 3D reconstruction and simulation was required. We are planning to perform lab anatomical segment S resection by using primary parenchymatous transection technique with application of ICG fluorescent imaging. The patient was placed on low lithotomy position, and the 5 ports placement were as illustrated. Starting with suprahepatic IVC dissection to expose the root of hepatic vein. Next step, the hepatoduodenal ligament was encircled and prepared for inflow control. The ultrasound was used to identify middle hepatic vein trunk and its branches in main portal fissure. The cutting line was marked over the middle hepatic vein trunk. The Pringle maneuver was done before parenchymal transection. The parenchyma was transected along cutting line by using CUSA. The one-off drainage vein of segment 8 was meticulously dissected, clipped, and then cut. The middle hepatic vein trunk and its branches were exposed and identified. The large drainage vein of segment 8 was dissected. Then the proximal part of main drainage vein of segment 5 was reviewed and preserved. The segment 8 vein was dissected, clipped, and divided. The further dissection was along drainage vein of segment 5, and dissection above this vein, the Christian pedicles were exposed. Then the tertiary pedicles were reviewed. The corresponding pedicle of segment 8 was selectively dissected, encircled, then clipped, and divided. The other Christian branch of segment 8 were encircled. Then clipped and divided. Following transection of all Christian pedicle of segment 8, the 2.5 mg of ICG was injected intravenously. The whole liver was emitted fluorescent within 1 minute except segment 8. The segmental border inside the liver can be visualized. The anterior fissure vein were identified, clipped, and then cut. Then superior right hepatic vein was exposed and used as the intrahepatic landmark boundary between segment 8 and segment 7. The other Christian pedicle of segment 8, which originated from right posterior pedicle, was found. So it can be explained why some area of segment 8 was stained by SCG dye. The plane between emitting and non-emitting area was dissected toward liver capsule. The liver capsule was cut. Then specimen was removed. The cutting surface revealed the landmark veins emitting transected parenchyma and G8 stump. Operative time was 310 minutes. Estimated blood loss was 30 milliliter. The patient can discharge on post-operative day 5 without any complication. The pathology confirmed hepatic adenoma with free all margin. From the two videos, I will conclude that the Christian approach, hepatic vein guidance, and ICG fluorescent imaging are the useful tools to perform precise lab anatomical resection. Thank you for your kind attention.
Thank you, Dr. Ravisak, for your very impressive presentation. And also, anyone who have a question, you can type on the chat box, and we will answer and in the last session. So we will move to the next speaker. Dr. Tan, we will introduce for the next speaker, please.
Our next speaker, Dr. Ji Hoon Kim. Dr. Kim, he had his residency and fellowship training at Seoul National University Hospital. His working experience, he has the academic position as a clinical assistant professor at Department of Surgery, Changbuk National University Hospital, and the assistant professor at Department of Surgery, Yuji University Hospital. Currently, Dr. Kim works at the Center of Liver and Pancreatobiliary Center, National Cancer Center, South Korea. Today, he will talk about the procedures based on the right posterior portal pedicles. Please, Dr. Kim.
Thank you, Chairperson. Good afternoon, ladies and gentlemen. I'm Ji-yoon Kim from National Cancer Center, Korea. Today, my talk is procedures based on right posterior portal pedicle. The Professor Kino proposed the three approaches to the portal pedicle, among them extrafascial approach and transfascial approach, Gleasonian approach. The extrafascial approach is a Gleasonian approach from the liver hilum, so-called HALA approach. On the other hand, transfascial approach is a Gleasonian approach from the liver parenchyma. Sujioka recently reported liver anatomy based on the Lennart capsule. The gap exists between Lennart capsule and plate system. The visceral peritoneum covers plate system and Lennart capsule. So, first step is dissection of visceral peritoneum for entering gap between plate system and Lennart capsule. The extrafascial approach can be divided into extrahepatic and intrahepatic Gleasonian approach according to destruction of liver parenchyma and Lennart capsule. This is a recent study about segmentation of right posterior sector. Bow shape type is 50%, bifurcation is 45%. In terms of technical difficulty, important factors are existence and length of common trunk and G6 and G7. No common trunk type is difficult type. The rubeolar sulcus is an important anatomical landmark for dissecting the right posterior portal pedicle or segment 6 pedicle. We reported the anatomical resection of segment 6 using rubeolar sulcus as an anatomical landmark. Content of sulcus was segment 6 portal pedicle. This is another report about right posterior sectionectomy using Gleasonian approach as an anatomical landmark of rubeolar sulcus. The content of rubeolar sulcus is right posterior portal pedicle. Another anatomical landmark for dissection of right posterior portal pedicle is a cystic plate and 2 cm right side of the cystic plate. Dissection at this point enables approach to the right posterior portal pedicle. Guino said the feasibility of this technique was around 70%. Based on the recent study, most anterior pedicle is within the 2 cm around the cystic plate, so-called the zone of 2 cm. This study supports the 0.2 cm right side of cystic plate for dissection of right posterior portal pedicle. In extrahepatic listening approach, traction and countertraction for entering gap is important. We usually apply the extracorporeal finger maneuver during the glistening approach. Extracorporeal finger maneuver is a good countertraction tool. I'll show video clip extrahepatic listening approach. With extracorporeal finger maneuver is applied for countertraction and dry field. The first step is dissection of visceral peritoneum. In extrahepatic listening approach, usual dissection tool are suction and bipolar forceps. You can see the larynx capsule and gently dissect it. And G1C is another important anatomical landmark for dissection of a right posterior portal pedicle. And you can see the larynx capsule. And entering and gap between larynx capsule and glisten. After clamping of right posterior portal pedicle, an ischemic boundary was checked by ICG camera. In intrahepatic listening approach, minor parenchymal transection was made at the 2 cm right side of the cystic plate and 45-degree angles. This angle is similar to right polar fissure angle. I'll show video clip intrahepatic listening approach. Firstly, we attempt extrahepatic listening approach, but there was no ischemic change. So we marked in 2 cm from right side of cystic plate, 45-degree angle. And this is right side of IVC, and minor parenchymal transection around the liver hilum was made. The small glycinium branch was ligated meticulously, and then this glycinium pedicle was identified, and then caudal lobe was transected, and then they encircled the right posterior glycine pedicle, and intrahepatic glycine approach was done. Right portal section was ischemic. Final subtopic is transfissural approach. Transfissural approach is originally proposed by Dong-Taek Dung. Bismuth called this primary parenchymatous technique. The principle of this technique is to begin with the opening of the liver parenchyma along the fissure, and then Gleasonian approach was done. Fissure line is intersectional plane. There are 5 fissure lines. Among them, the right polar fissure and anterior fissure is useful for dissection of right posterior portal pedicle. The exact location of the right polar fissure is not well defined because it has no external landmark. The right polar fissure is inclined 40-degree angle to the right, so we can identify the right polar fissure after clamping of posterior portal pedicles. The anterior fissure is between the ventral and dorsal segment of right anterior section. Landmark vein is anterior fissure vein. These are our published articles about transfissural Gleasonian approach. Most articles are anatomical segmentectomy. Transfissural Gleasonian approach is useful not only anatomical segmentectomy but also sectionectomy. Last one is about right anterior sectionectomy. After opening of the liver parenchyma along the anterior fissure and then the right posterior Gleasonian pedicle G6 and 7 was done. This is a transfissural Gleasonian approach for extended right posterior sectionectomy. This is anterior fissure vein is a borderline between the dorsal and ventral area. In this case, G7 and G6 have no common trunk. We check the anterior fissure line by laparoscopic ultrasound, and anterior fissure vein was checked. First, parenchymal transection along the anterior fissure, and we dissect the G5 dorsal small pedicle and dissect G6 pedicle. Was dissected and ligated, and we dissected along the anterior fissure vein, and we dissect G8 dorsal pedicle and looped and clamped. We checked the ischemic line, and G7 and segment 7 area non-ischemic, and segment 8 dorsal is a ischemic area. And after opening of anterior fissure, and we dissect G7, G7 pedicle transected, and then G8 dorsal pedicle transected, and then the parenchyma transection along the intersection of plane. This article summarizes the characteristics of extrahepatic, intrahepatic, and transfissural glycinian approach. Our surgical strategy are as follows. The extrahepatic glycinian approach is first attempt. The intraglycinian approach was applied in case of difficulty of the extrahepatic glycinian approach, obscure anatomy around the plate system, glycine pedicle with deep location inside the liver. A transfissural approach is applied in a failure of extrahepatic and intrahepatic glycinian approach and variation and tumor close to the liver hilum. Thank you for your attention.
Thank you very much, Dr. Kim, for the wonderful video presentation and showing us how to approach the right posterior portal pedicles. So as we previously mentioned, if you have any questions, please leave your question in the chat box. So before we start another important presentation, the expert talk, we would like to present the 5-minute video, which is about the technology and innovation by Medtronic. Please accept my apology. I think it's about 5 minutes, but actually it's 1 minute. So we will proceed to our next speaker.
Okay, our last topic today is very important because it's a topic for the expert talk. Today we are very lucky to have the world famous in the HPV surgeon, and he is very busy, but he really kind to give us opportunity to have a talk today. Our expert talk will be presented by Dr. Go Wakabayashi. Dr. Go is graduate medical degree from the Keio University School of Medicine, Tokyo, Japan. He trained at the Department of Surgery at the Massachusetts General Hospital and Harvard Medical School. He has operated more than 150 cases of the living liver transplantation and over the 3,000 cases of the HPV surgery and the laparoscopic surgery. He has a lot of publication, over more than 300 peer-reviewed articles, and also in a book chapter related to the HPV surgery. Right now, Dr. Go, he is the director of the Center for Advanced Treatment of the Hepatobiliary and the Pancreatic Disease, and the chief of the Surgical Service RKO Center, Central General Hospital, Saitama, Japan. So Dr. Go will present us today. The topic is the laparoscopic anatomical liver resection with the glycinial approach from the hilar place. Professor Go, please.
Thank you. Thank you very much for your kind introduction and precise introduction. And also thank you very much for inviting me. It's a very important Okay, can you see my screen? I guess yes. So I'm going to talk about laparoscopic anatomical liver resection with the Gruson approach from the hilar plate. I have no COI to be disclosed. I'm going to show you two videos. One video is made by Dr. Kohei Mishiba. He's just 12-year post-graduation. I just wanted to tell you if the technique is standardized and even a young surgeon can perform a nice surgery like this. So the patient is an 80-year-old male with sigmoid colon cancer and the metachronous colorectal liver mets. So CT MRI revealed a 20 millimeter tumor in the segment 5 and 8 of the liver. And hepatic reserve is nice. Child-diffuse score 5. IgG retention test is 8%. So that means that we can remove 70% of the liver. So this is a preoperative imaging. We do routinely perform this type of preoperative imaging to see where to cut, how much the volume to be removed, and what kind of Grisson and pedicle we have to sacrifice, what kind of which veins we can divide. Those information we obtain beforehand surgery. And also it's important to compare the shape of the area to be resected. So we refer these 3D simulation. Actually, it's 3D with glasses. During the surgery, we use it as a navigation. So this is an IR, laparoscopic right anterior sectionectomy. So he's trying to preserve a lana capsule to take anterior trunk, and he found a small branch. We name it as a anchor, then we can sacrifice it. Once we name it as an anchor, we can sacrifice it. So anyway, so we try to visualize the root of anterior trunk. So we have divided the 3 anchors. I believe those areas, in charge for these 3 anchors must be very small. So now anterior trunk is taken, but as you can see, Professor Ji-Hoon Kim nicely described, this is the intrahepatic Grisson approach. We always tell young surgeons, don't hesitate to break lana capsule. It's better rather than breaking Grisson and sheath. Once you break a Grisson sheath, you're going to be in trouble. You might encounter delayed bioleakage. So after the clamping of the posterior anterior trunk, we asked anesthesiologist to give 0.5 milligram per body of indocyanine green IV injection. So we checked the dosage and we realized this is the most appropriate. The smaller doses is better. Then you can visualize nice plane, intersectional segmental plane. It's a border between the shining green area and no shining green unperfused area. So this is a border between segment 4 and segment 5. So once you enter appropriate intersegmental plane, you don't feel anything, not too much. Then you can divide the parenchyma using a cursor like this. And also you can use the crumb crush method and to open the parenchyma intersectional segmental plane. As you see, only a couple of thin structures running across the intersectional plane. So usually that is only a hepatic vein, or Professor Sugioka mentioned it. That's a kind of a peripheral part of a lana capsule. It becomes like a structures. Become small structures. Then we found a midhepatic vein and the V5 going into the midhepatic vein. So a couple of V5 is divided. And we knew beforehand in a preoperative simulation, there's a main branch of a midhepatic vein is running across anterior trunk. It's going to the segment 5. So we have to sacrifice. But this is also going to segment 6. So some midhepatic vein comes from a segment 6 as Professor Monden described. So this main middle hepatic vein has to be divided. It's a V5, and later we're going to divide it on the side of a V6. So country line is now open by a cursor. Cursor has to be moved from cranial dorsal side, from behind. So hepatic vein has to be exposed from cranial to caudal. So that means the movement of the cursor should be dorsal to ventral. Anyway, so we're gonna expose the middle hepatic vein. It's pulsating like this. Then we are reaching towards the root of right hepatic vein. As you see, nicely visualized intersectional segmental plane. This is a intersectional plane between 5, 8, and 6, 7. So now anterior trunk is divided by stapler. Then you have more space to visualize the right hepatic vein. Again, the movement of the cursor has to be from cranial to caudal, so that we can avoid split injury of those veins. This is a V8. One of the V8 is clipped and divided. So anterior sectionectomy is going to be completed. I think it's a nice surgery done by Dr. Mishima. He's just 12 year post-year graduation. Nicely done. Right hepatic vein is pulsating. This is another example which I performed lately, IR laparoscopic left paramedian sectorectomy of breast cancer liver metastasis. We place Pringle maneuver like this always. Then we place end loop on the round ligament so that we can move the liver, or the left liver, as you preferred. Then I try to open the Grissom pedicle above G2, beneath G3, and also beneath G4. This is the area to be clamped and to be divided so that we can perform paramedian sectorectomy. Again, I don't mind breaking liner capsule. It's nice if we can preserve a liner capsule, but it would be better breaking liner capsule rather than breaking Grissom sheaths. Then the area, root of G3 and G4 is now taped and divided. And again, indocyanin green 0.5 milligram per body is going to be IV injected. Then we see a nice green area. That is a green area for the right side of the liver. It's a country line between 4 and 5 and 8. Then we start Pringle. I want to show you this newly developed microwave scissors. So this is made by Nikiso, Japanese company, and I hope it will become available all over the world in a couple of years. So if we enter appropriate intersegmental sectional plane, as I said, you will not encounter any Grissom pedicle. You just see some hepatic vein running across the intersectional segmental plane, or running along or crossing intersectional segmental plane. Then we can use this scissor to do a sharp dissection. That is our rationale to develop this new device, but we need to have some ability to stop bleeding. So, as you know, microwave is the most powerful energy device to stop bleeding. So Nikiso created this microwave scissors. Then I move the ground towards the right side. Then we start division between the segment 3 and 2. So shining green area is a segment 2. We're going to leave those segment 2 and we're going to remove only 3 and 4. It's paramedian sectorectomy, which was defined by Brisbane terminology. Actually, it's a French name, sectorectomy. So Quino is defined. Left hepatic vein only runs between segment 2 and 3. So some part of a segment 4 area was left. I mean, the place where we clamped is a little bit above this Grisson pedicle segment 4. So some part of segment 4 is left. Again, Pringle is performed. Then we're going to divide parenchymal transection between segment 4B cone unit area. Then we found one Grisson pedicle goes towards the segment 4B. So this is intersectional plane between segment 2 and 3. As I said, it can be divided sharply because no Grisson pedicle exists between those areas. So sharp dissection is faster, and I think if you, this is my couple times. This is my first time maybe a couple times, so I have to get used to use this nice sharp dissectors. I mean scissors. This is one Grisson pedicle goes to segment part of a segment 4B, so we have to divide it. Then I try to find the middle hepatic vein, because middle hepatic vein is a border between segment 4 and segment 5A. Again, intersectional plane does not contain any important Grisson pedicle structure, so it's only small structures like this. Maybe peripheral lanic capsule, as Professor Sugioka suspected. I don't know. But again, sharp dissection, you can perform sharp dissection if you enter an appropriate intersectional segmental plane. Then we can see some part of the middle hepatic vein. So I'm trying to expose the middle hepatic vein by this microwave scissors. So B4, we found B4 and some bleeding and the clipped. B4 is divided. Keep exposing middle hepatic vein and a couple of B4 we're going to divide. This is one of the B4, another B4 divided. So sharp scissors, I mean microwave scissors, work nice to cut the hepatic vein. But I tried to use this microwave scissors as if it's CUSA, but probably I need to learn a little bit more tips if I can accomplish a nice dissection like Caution Chan and Ramswick. So B4 is divided. Then we are approaching a root of middle hepatic vein and the root of the left hepatic vein. So actually, this is a country line. So no Grisson pedicle running across the country line. Only a couple of B4 or B5. So finally, after opening the liver, we're gonna clip and we're gonna staple the root of segment G3 and 4, the root of paramedian sector. So this green area is a little bit, I think, a mistakenly stained, because I left one of the segment 4B cone unit area. So now, root of paramedian sector, is now divided by stapler. So it's nicely done. But some bile leakage, I believe, occurred. Then I placed a clip. I think that sometimes, stapler creates some bile leakage because stapler actually makes a hole in hepatic duct. So clip is better, or ligation is much better, in my opinion, to prevent the delayed bile leakage. So I'm trying to visualize the hilar plate, then finally approaching the root of mid-hepatic vein, as well as the root of left hepatic vein. So now opening up surface. I didn't tell you, I always tell young surgeons to open up liver surface first, the area to be resected, along the area to be resected, so that the liver can become movable. I think laparoscopic surgery needs move the ground fairly. So liver is very hard to move the ground. But if you perform superficial parenchymal transection first, area to be resected, then you can have a movable liver, so that you can adjust your devices along the plane. So now sharp dissection of the appropriate intersectional plane, I'm doing, keep doing. So I think it's nice, although I need to be improved a little bit more. But it's a nice microwave coagulation. You can stop bleeding. Then also, once you enter the nice appropriate plane, between green shining area and non-shining area, you become very much fast to cut the liver. So this is my team. We perform 1,500. I think. So this is my team. I have to be a little bit back, but it's okay. It's almost done. So this is my team. We perform 1,500 GI surgery a year, including 400 cases of HPV surgery. I'm always thankful to my team. Thank you very much for your kind attention. Please email me when you have a question. Thank you.
Okay. Thank you, Professor.
Okay.
Thank you, Professor Ko. That's a very excellent and very impressive for your presentation, and a lot of experience from you. We have learned a lot from your video and your technique. Thank you so much. So we will move to the next session.
Yes, now we have the Q&A, including panel discussion. So may I ask all speakers to turn on your camera, please? So today we have about 160 participants, and in the mailbox, I think we have totally a few questions. One question is already answered. It's a question for Professor Shan from Dr. Pei Papa Kyo. I'm sorry if I said incorrectly. So Dr. Papa say, thank you very much for your excellent laparoscopic right hepatectomy using harmonic. May I ask one question? If you are doing laparoscopic right anterior hepatectomy after doing left-sided parenchymal transection, how do you approach on the right side? Cranial caudal or caudal cranial using the harmonic? Thank you very much in advance, Professor Shan. Professor Shan, would you like to answer live?
Yes. I think this question is quite important, especially in a very advanced procedure like the double-score right anterior sectionectomy. My approach for this is to open the right parenchymal transection frame around the demarcation. Of course, we need to clamp the right anterior perisonial pedicle. So my approach usually is to open the parenchyma between right anterior and right posterior perisonial pedicle. If we get good exposure, we can divide the right anterior perisonial pedicle. So this is my approach to the right transection frame.
So the next question to Dr. Go. Thanks for the excellent webinar. My question is to Dr. Go. Could we divide the Gleasonian pedicle of the segments intended for resection during the initial part of the surgery rather than at the end? Dr. Go, please.
Yes, I think this is a very important question. And we usually perform Gleason division at last and not the initial part, because after opening the liver, again you can apply a stapler or you can apply clip as you like, because the area was widened. Otherwise, you have to use a stapler at the initial part of a Gleason pedicle taping. It must be restricted, the movement. So I think after opening the liver opening, it's better to place a stapler or clip over Gleason pedicle. So we perform Gleason division, not at the initial part, but after initial part, maybe close to the last part of a division.
So how about the other speakers? Dr. Kim, Dr. Monden, Dr. Lawisak, Dr. Chen.
Same as Dr. Go Wakabayashi, and I think we need to wide space to go to use stapler. So, but yes, I use the I made a wide space to use stapler.
For me, I think same as Professor Go and Professor Monden. The technique is the same. Yep.
I also the same other expert, and in left hepatectomy, the only phase of transection of left gleason is more feasible because of the initial part of the surgeries. We make the more space other than right anterior or right posterior. So I usually in left hepatectomy, left gleason approach is only phase transection is preferred. Other right posterior, right anterior is the initial phase of transection is a little bit difficult. In that case, I have to make a space and then after parenchymal transection and then transect the right anterior, right posterior gleason pedicle.
Thank you very much. I think it's kind of the consensus that we will divide the Gleasonian at last after we complete the parenchymal transection.
Okay, for the next question, I think because the audience saw a very fast video from all the speakers, the question is, what is the operative time difference between the open and the laparoscopic left hepatectomy? Which one is the quickest? Anyone? Professor Go, please.
Okay, let me answer first. I think many paper, many case series, many comparative studies show that laparoscopic liver section takes longer time, but less blood loss. So especially for left hepatectomy, and I think usually left hepatectomy can be done by upper midline incision for open left hepatectomy. So it doesn't take too much time and doesn't take too much time for closing and opening. So maybe open left hepatectomy is quicker. But once you get used to do left hepatectomy very nicely by laparoscope, it will be very quick, like less than 2 hours, or maybe almost close to left lateral sectionectomy can be done like in an hour. So I don't think the time during operative time or duration doesn't mean many things. The importance is quality of life after surgery, or maybe less complication, or less blood loss, less blood transfusion rate. So all those things, lap liver surgery is superior than open liver resection. Data shows that evidence. Thank you very much for this question.
Yeah, the other speaker, maybe Professor Chen, how about you?
Yes, actually, I believe that not in the future, not far from now, maybe we can do laparoscope or liver resection quicker than open, because especially for right posterior or superior segment, usually in open liver resection you need a thoracic abdominal incision. To open and close this kind of wound will be very time consuming. And nowadays we have more routine reproducible approach for the resection by laparoscope in this area. So I strongly believe in the near future, maybe we can do it quicker than open approach. So I want to echo Professor Okabashi's opinion that some standard procedure like that, standard left, standard right, I believe nowadays in the hands of many experts, I think it could be as long as the open approach, maybe quicker than open approach. So I think it's not always laparoscope will be longer than open. If you think about laparoscopic cholecystectomy, initially it's longer than open, but nowadays it's almost always quicker than open. So in my opinion, maybe not far from now, we can have quicker laparoscopic liver resection.
How about you, Dr. Kim?
Yeah, I'm agree with the Kuwakabashi and Question Chen, and usually open left hepatectomy is performed in more difficult and complex case in usually classic tumor in needed for the HJ and the lymph node dissection. So operation time it depends on various conditions, various situations. So, in my opinion, yeah.
Thank you. How about Dr. Monde? Dr. Monde, how about you? About the open and the laparoscopic left hepatectomy?
Yes, yeah. I don't think there is a significant difference between open and laparoscope, but I think open is a little longer time. But Professor Go Wakabayashi mentioned, and good quality for patients is most essential, I think.
And Dr. Louisa?
Okay, from my experience, open approach is a bit quicker than laparoscope, but in the that is a term of operative time. But in overview, I think we can get surprise or impressive operative view, magnified view of the imaging, and safe shorter stay of the patient. I think overall laparoscope for left hepatectomy should be a standard of care.
Thank you.
Thank you very much. I think we now have a lot of new questions. Let's go to the number 5. So from Dr. Jimmy Lee, this question is for all speakers. Do you always obtain 3D liver remodeling prior to anatomical liver resection, especially segmentectomy, or is a conventional CT triple phase or MRI is sufficient to look at the vessels? Anyone would like to answer first, or?
I think not our case that we do 3D reconstruction. We perform only the difficult case, something like that, the segmentectomy, and we know that in the right side there's a lot of variation of Christian pedicle, so 3D imaging can give other information, and we can do it precisely in difficult cases.
As I presented, I do always obtain 3D liver remodeling, and also during the surgery, we view 3D with my glasses. So that is very good. I think it's a quite new technology, and should be propagated, should be diffused everywhere, because you have to know the direction of a Grissom pedicle, 11 o'clock, 10 o'clock. You know, this type of 3D image is very useful once you use during the surgery.
In my opinion, is a 3D reconstruction image very useful and helpful, and the 3D images have the good quality of relation tumor and vessel look. And another important thing is preoperative simulation. The 3D reconstructed image, we can see the caudal view or ventral view or something like that. And a complex case in segmentectomy, circumcectomy is mandatory for the 3D simulation image. And nowadays, routinely use second order pedicle or sectionectomy or right and left hepatectomy is also, we have all case, we have the 3D reconstructed imaging. Yeah.
I totally agree. Actually, I suggest to have 3D or image reconstruction before the surgery in every case. I will try my best to obtain the reconstruction image. I think it's very helpful, even for standout case. It really help to shorten the operation time. So I strongly suggest that we obtain 3D reconstruction before surgery.
I always use 3D simulations. It is essential to understand precise vascular trees by using 3D. And Dr. Wakabayashi mentioned that major hepatic veins do not always run the intersectional plane. And there may be alternative smaller veins. So it is easy to identify those smaller veins. So I always use 3D images.
Okay, thank you very much.
Okay, for the next question from Dr. Bob Pala. Thank you for the excellent webinar. My question is, how about the rate of the bilic in a microsisor ultrasound? Which better between the harmonic or CUSA for the liver parenchymal transection and your choice of instrument? Thank you. May we start with Dr. Kim?
Yeah. To prevent bilic is important thing is, in my opinion, important thing is dry field and meticulous dissection, secure ligation. As the CUSAR or energy device is also important, but more important thing is dry field and secure ligation and safe dissection, in my opinion.
Thank you. Dr. Monden?
I haven't used micro scissors, but yes, but intersectional plane, there is no glucinia pedicles, small branches. So even Cursor or harmonic scalpel is both is can dissect smoothly. So yes, smoothly.
Thank you. Professor Chen.
Yes, actually in this webinar, I think Professor Kapasi just showed us that a very important and a commonality that there's no horizontal pedicle branches along in the intersectional plane. So in that case, if you are doing anatomical resection, I think the risk of biologic will be very minimal. So I think the important, I would also like to echo the opinion of Professor Kim. If we are doing anatomical resection, we follow the trajectory of the portal area, the risk will be minimal. So I suggest to do anatomical resection, to apply the bone unit concept to do the resection. In that case, I think the biologic risk will be minimized. No matter what kind of parenchyma transaction tools you are using.
Okay, Dr. Ravisak.
Okay, to prevent bile leakage, I think it's not depend on the device that you use for parenchyma transaction, but it depends on your technique that you should clearly dissection and then clip, then divide it. So for Christian pedicle, even the small, I usually clip before divided.
Thank you. And Professor Go, and you show us about new scissor for the microwave. How about you?
I think by leakage, we used to think by leakage, must be depend on, the parenchymal transaction, whatever energy devices you use, or precise parenchymal transaction is better. But lately we experience a kind of a delayed by leakage. So probably those by leakage come from stump of a horizontal pedicle, which we clip or which we stapler divided. So we have to know exact mechanism why such kind of a delayed by leakage happen for some patients, because we believe operation was perfectly well, but 1 week later, just before the discharge, patients start to have a delayed by leakage. So we don't know why. Those leakage usually come from a stump of the horizontal pedicle, which we ligate, which we divide. So maybe we have to think about the ligation, then clip. Don't use a stapler. I don't know. We have to, I think, do some study, or we have to be more careful about those delayed by leakage. Maybe our series are quite unique because we always perform anatomical resection from a hilar plate, clamping, dividing the horizontal pedicle cone units, and those small, even those small stumps might result in delayed by leakage. Maybe clipped, might have been dropped off. We don't know yet.
Thank you.
Okay, let's move to the next questions. I think now we have 5 questions left. So the next question is from Dr. Rapi Pat. How about the ICG doses after pedicle clamping for negative staining in laparoscopic hepatectomy? Dr. Chen?
I think I used to use the positive staining or ICG technique. So actually, all radiologists that do the ICG or polar vein selective staining. Usually our radiologists, they will calculate the volume of the segment to be stained. So they will calculate the dosage for that. So it depends on the volume you are going to stain when you are using the positive staining. Now, for negative staining, I think it's maybe 1 milligram or 2 milligrams systemically, I guess.
Professor Gold, please.
Yeah, as I presented, I've been presenting the same dose, like 0.5 milligram per body. So I think it's very much diluted as a negative staining, but once you try to use it as a positive staining, you have to dilute 1/10 more. So 0.5 milligram per body for negative staining, and probably 0.05 milligram per body of positive staining. Because diluted DICG is better, because if you give very concentrated DICG, probably 1 hour later, it comes back from a hepatic vein, and everywhere becomes green, becomes shining green. So if you want to try a nice division of intersectional segmental plane between green and the not green area, maybe you should use a diluted one, like a 0.5 milligram per body. That's our conclusion at this moment.
Thank you. About Dr. Kim?
I usually use the negative staining. I have no experience positive staining. And in negative staining, after clamping at least 5 minutes, I will inject in usually dose 2.5 milligram. And sometimes it depends on the company ICG. The Olympus or Storage Strikers have a different sensitivity, but in our center is usually use the 2.5 milligram for the negative staining. Yeah, used.
Dr. Monten?
I usually use negative staining, and I inject 2.5 milligrams per body. I think this is high dosage compared to Dr. Wakabayashi, because I only identify the demarcation line, so I do not use re-injection. And also, we don't have a side view camera, just only camera, so that's only identify demarcation line.
How about Dr. Ravisak?
Yeah, first of my experience, I used full dose of ICG, same as we use in liver function test. And we got a problem that, as Professor Go said, there's a reflux of ICG from the hepatic vein into the cramp, the demarcated liver parenchyma. So now I decrease the dose for negative stain to only 2.5 or 0.05 milligram. So only 2.5 milligram I think is enough for negative stain.
Thank you. So we move on to the next question.
Okay, the next question from the Dr. Papala. How much the intra-abdominal pressure to be kept for safe for the laparoscopic hepatectomy? Maybe start with Dr. Monden. How much of the intra-abdominal pressure do you use during the laparoscopic hepatectomy?
Abdominal pressure?
Yes, pressure.
Yes, I always set about 10 millimeters mercury.
Okay.
Yes, I don't increase the intra-abdominal pressure.
Okay. Dr. Chen, how much do you use?
I did not change the setting of the insufflator, so I used to use the pressure. It's about 15 millimeter mercury, but because I use a suction almost always, so I would sometimes I check the pressure monitor. It's about 8 to 10 millimeter mercury in my case.
Okay. Dr. Kim?
I try to maintenance of 12 millimeter mercury. So sometimes Goshin Chen said that the suction is pneumoperitoneal pressure decrease. So at that time I set of pneumoperitoneal pressure is 15 millimeter mercury. I try to maintenance of 12.
Yeah. And Dr. Louisa?
For me, 12 to 15, and depend on the space that we would like to create.
Okay.
Maximum is 15.
15. Okay, Professor Go?
Yeah, 10 usually, but sometimes up to 12.
Okay, thank you.
Thank you. So we go to the next question. Dr. Jamia, is there standard port positions for laparoscopic hepatectomies? I think this question you need to answer in details a little bit. Dr. Ravisak?
Okay, mostly I use the 5-port technique. The first one is supraumbilical area, and the second one is also fixed, is just below the xiphoid process, and the other two is for surgeon, is on the right side, and the other one for assistant on the left side. Totally 5 choker.
Professor Go, please.
Yes, our standard port position is very much well standardized, and camera port always go to the navel area, and including a camera port, we have 5 ports. Every port is a 12 millimeter, so that we can place ultrasonogram and we can take gases from everywhere. And one port should be placed in near xiphoid area and mid-clavicular subcostal area, and always standardized. So even the tumor is right side, left side, and operator uses mid-clavicular port, that kind of things. So every liver resection can be done with the same port. That's my opinion.
Thank you. Dr. Kim?
In usually right and left hepatectomy is similar. The common approach is supraumbilicus, and I usually use the 5 trocars. But in segmented 7, in case of segmented 7 is the camera port is right upper quadrant, and it depends on the some procedures. I usually use the working port is the subcostal area. Yeah.
Dr. Monden?
Yes, depends on the procedure, but right side hepatectomy, I set the left hemilateral position and I place 5 port beneath the costal arch, and I sometimes use intercostal trocar, especially for segmentectomy 8 or segmentectomy 7.
Thank you. Dr. Shun?
I almost always use the 5-port technique, but because I'm using the rigid 3D or imaging system, so if I'm doing 8 dorsal, segment 8 dorsal or segment 7, maybe I would move the camera port to the right upper quadrant port. And I would, like Professor Monten said, that in this upper segment, I will use the intercostal port. But it's usually 5 millimeter in the costal port for upper segment.
Thank you very much.
Okay, for the next question from Dr. Pepapa Kayor. Thank you very much for the organizing such a webinar frequently. Thank you for our professor for excellent talk and demonstration. May I know the role of the enhanced recovery program in MAS, LLR to LLR alone could provide short hospital stay and as a such. Thank you. I don't know. Do you understand the mean for the MAS?
So it should be like the ERAS program or something?
Yes, I think so. Do you have an ERAS program for the hepatectomy in your hospital? Maybe we start with the Dr. Kim.
Yeah, in our hospital, and I do not follow the ERAS program. Yeah, so, but usually in laparoscopic liver resection is have a faster recovery and early discharge than the open liver resection. But our center do not follow the ERAS program. But I prepared the ERAS program in lab liver resection in the future.
Okay. And Dr. Chen, do you have the ERAS program?
Actually, we don't have the formal ERAS program for lab liver, but actually, our practice actually follows some principle. So therefore, in our patient, there will be no NG tube after the surgery, and also the patient will be allowed to resume their oral intake just a few hours after the surgery. And also, they are very encouraged to resume ambulation after the surgery. So the usually hospital stay after the laparoscopy usually is maybe 5 or 6 days after the surgery. So we don't have that, but I follow the spirit of the ERAS.
Okay. And Dr. Lavisak?
Yes, in our center, we did not have ERAS program. We use our lab policy for the patient perform minimally invasive surgery, and we just apply some point from ERAS to our policy.
Professor Ko?
Actually, we don't follow exactly the ERAS program, original ERAS program, but we take some idea about no nasogastric tube, no drain, and early mobilization. We have more than 200 physical therapists in our hospital. So patients usually, stand up after surgery and then, next day and start meal and, that kind of thing. So we don't follow exactly the ERAS, but we take an idea from you, that kind of thing.
Yeah.
That's modern school.
It's like you have the ERAS program, so. And what about Dr. Munden?
Yes, in our institution, we don't apply ERAS program, but we start eating the day after the laparoscopic surgery. But in Japanese insurance system, it is quite difficult to discharge the hospital earlier. There is a social institutional factors.
Yeah, maybe the same in Thailand also. Okay, we move to the next question.
So we have 3 more questions. We're going to go a little faster. So from Dr. Chon Wee Chai, he has 2 questions. First, about the energy device during laparoscopic setting. When to use the harmonic plus CUSA or only harmonic? This is his first question. Do we need to use the CUSA or just only the harmonic? Dr. Lavisak, please.
I think it depends on the available of the device in each center. In our center, for dissection, we use CUSA, and for transection, we use other sealing device, such as ligature.
Dr. Chen?
I think the post-CUSA and harmonica are very useful instruments for functional testing. I think both of these instruments can do in laparoscopy transaction. Personally, I prefer harmonic all the way, but I think the CUSA is also very useful.
Dr. Kim?
I usually use the superficial parenchyma transaction was performed using the energy device, and deep parenchyma is CUSA, and in most proper surgeries, this kind of surgery by CUSA and energy device. And
Dr. Monden?
Yes, it depends on the situation. I always bring the both CUSA and harmonic scalpel. Is that answer? Yes.
Dr. Tan, we don't hear from you. Dr. Tan? Okay, sorry, we don't hear from the moderator.
Can you hear us? We wholeheartedly apologize for the technical error. So we come back. We come back to the questions. So how about Professor Go? When to use the harmonic only or the harmonic plus the CUSA?
I think we used to use the CUSA a lot, but I try to train young surgeons to use only a harmonic or clash, whatever, sonication, whatever, and because CUSA is easier and safer. But once you get used to do a clamp-crush method like Professor Koshin Chen, he's an expert. We try to learn how to perform his technique so we can save money. Don't using a CUSA. But CUSA is a very good device. And once you want to open, once you expose major hepatic vein, I'm more confident to use the CUSA rather than using other energy devices, which I showed you today, like microwave scissors. Try to expose hepatic vein, but I was not so comfortable. I was scared if I can tear the hepatic vein. But CUSA with tissue select mode never injure hepatic vein, never injure mucosal pedicule. That's my experience and opinion.
Thank you. So just one quick question. The question is about when you want to control the pedicle with the stapler, is it the lower incidence of the bile leakage? Yes or no? Professor Chen?
Actually, I agree Professor Okabayashi's opinion. I think the ligation outcome is better than stable. Because to choose a suitable height of the staple, sometimes it's not always possible. So I prefer to come with this hemorrhoid. But sometimes the pedicle is just too wide to be clamped by hemorrhoid. In that case, I will use a staple. But I will check the staple line very carefully. Sometimes I'll put stitch suture on it to prevent it.
Dr. Monden?
Yes, it depends on the situation. If Brucena pedicle is thick, I use a stapler. But if it is Brucena pedicle is thin, I use clip and ligate.
Okay. Professor Go, please.
Well, we used to use stapler a lot. Actually, any anterior pedicle or posterior pedicle or left pedicle, we didn't have any hesitation to use a stapler. But lately, I have some kind of suspicion. If we use a stapler can make a hole on the hepatic duct, so it might create some bile leakage. So as much as we can perform a nice ligation clipping, we try to avoid using a stapler. But I showed you my video, I use a stapler.
Dr. Kim?
Yeah, I agree with Go Wakabayashi and Go Shin-Chen and Bondon, and I have some experience of the bile leak after stapling. So I try to, a small sided glycinus, I try to ligate with the hemorrhag or clip. For large side, we staple used, but I agree with other experts. Yeah.
Dr. Lawisak, please.
Yes, for most of my case, I usually limit the usage of staple not more than two cartridge because of the cost. Sometimes we have to use three cartridge. For the small size, I think block clip or double clip and then seal with sealing device, I think enough. So the size less than 10 millimeter, I prefer Hemlock clip.
Okay, maybe the next question. The question is from Dr. Anang Nokoho. Asked about the pathological exam. How about after resection, the result of the pathological examination is still positive margin? I think we maybe compare with the laparoscopic and the open. How about the positive margin in the lesion that we resection? Okay, maybe start with Dr. Kim.
It's difficult to hard to answer. So nowadays, with the development of technologies such as ICD camera, we check the tumor margin, and so it is difficult to answer. Yeah.
Thank you. Maybe Dr. Chen.
I think the positive margin after laparoscopic resection actually is very, very rare in my practice. Nowadays, I have more than 1,500 cases. To the best of my knowledge, I never experienced one. So if you follow the transaction plan, especially anatomic section, use the intrahepatic vasculature as a landmark, I would say that it's quite reproducible to achieve a margin-free resection. even in laparoscopic case.
Okay. Professor Ko, how about you?
Yeah, I understand the reason why this surgeon questioned this, because when I use a hand, when you perform an open liver resection, you can feel the margin of the tumor. Then you feel safe and secure to have a nice positive margin. But in the laparoscopic liver resection, it's difficult to have a tactile sensation of the tumor. But you don't use ultrasonogram frequently because it's not so easy. So, and maybe IgG is good, but that's why we started to use anatomical resection even for colorectal liver mets to secure the safe margin. And also we refer preoperative stimulation, and we use it as a navigation. We have thinner margin, then we little bit take more liver parenchyma at that side. So you can overcome this positive margin status for lap liver resection. Theoretically, open liver resection has less positive margin, but in reality, lap liver resection does not have such a high positive margin tumor resection, in my opinion.
Okay, Dr. Monden.
Yes, I always check intraoperative time by macroscopically or ICG test. So I have not much experience, but if pathological examination is still positive margin after surgery, cross follow-up is better option, I think.
Okay, Dr. Ravisa.
Yes, I think it's important to set the landmark and use the technology such as ICG, ultrasound, and intrahepatic vein as a landmark, and we just follow that landmark and follow it to prevent positive margin. In some case that we have to expect that the result will be positive, some case that the tumor attached to hepatic vein that we think for colorectal liver metastasis is positive, but we accept that situation.
Thank you.
So I think it's been over 2 hours for our webinar, and there's still a few questions left. But I would like to ask all speakers, if you have available time, please go to answer at the chat box. And I think currently, it's very late in Japan, in Korea, and in Taiwan, right? In Thailand, we just reached just only 8 o'clock. So I think it's about time to end the webinar. So on behalf of the Thai National Cancer Center team, we would like to thank all speakers for the wonderful talks and presentation, and also thank every participant for joining us. I wish all of you enjoy today's webinar. We also sincerely thank Medtronic for organizing this wonderful webinar for us. Before we close the session, I would like to ask you all to do the evaluation form, which will pop up after you leave the webinar. Your feedback is valuable for us to improve our next one. And currently, the COVID-19 infection is spreading worldwide. The infected number is now over 150 million patients. Please take best care of yourself and family. Thank you everyone again. Good night and goodbye from Thailand. สวัสดีครับ
Goodbye.
Night.
Goodbye. Thank you.
Thank you.
Have a good night.
Thank you. Thank you very much.
Have a good night.
Thank you. Thank you.
Thank you.
Goodbye, Labzak.
Thank you. Thank you everyone.
Goodbye, Jin Ho Kim. Yeah. Hi.